Most bladder infections in later life begin quietly in the gut, and the signals show up in the bladder only after weeks or months of small shifts inside the bowel and the pelvis. This hidden link explains why many older adults are treated again and again for bladder infections while the real driver in the gut is left untouched. You are not broken, and you are not weak. You are living inside an aging system that changes how microbes move, how the bladder empties, and how the bowel behaves. When we address the gut first, bladder infections often become less frequent, less severe, and easier to manage. Before we go further, subscribe so you do not miss the next lessons that build on this foundation. Your bladder lives next door to your bowel, and age changes the neighborhood. The microbes that cause most urinary infections live in the bowel, not the bladder. Escherichia coli and other intestinal bacteria sit in the rectum and on the skin around the anus. With time, the tissues between the bowel, the vagina, and the urethra become thinner and drier, and the defenses that used to keep those bacteria at a distance become less reliable. After menopause, the local environment in and around the vagina loses some of its natural acidity and moisture, and the helpful lactobacillus species fade. As a result, bowel microbes gain easier access to the entrance of the urinary tract. This does not mean you are unclean. It means the biology of this area has shifted, and it can be shifted back towards safety. Because estrogen falls after menopause, the vagina becomes less acidic, lactobacillus levels fall, and bowel bacteria settle more easily near the urethra. Restoring tissue health locally can shift this back in your favor. The map matters because tiny distances shape big outcomes. Picture 3 doorways only a short step apart: the rectum, the vagina, and the urethra. They are neighbors. When the bowel is backed up or the rectum stays full 4 days, it pushes forward and changes angles in the pelvis. That pressure can pinch the urethra during urination and can twist the bladder neck just enough to trap residual urine. Residual urine is a warm, sheltered space where bacteria multiply. When residual urine sits day after day, a small population becomes a large one, and the culture the following week looks like a fresh infection even though the story began earlier with stool sitting in the rectum. The first clinical question with any repeated bladder infection in older adults is not only which antibiotic to use. The first question is whether the bowel is moving well and whether the bladder is emptying well. Constipation is not just uncomfortable, it is a mechanical driver of urinary infection. Consider the mechanics. Hard, infrequent stools and chronic straining enlarge and desensitize the rectum. An enlarged rectum acts like a firm pillow pressed against the bladder outlet. Even a moderate stool burden can leave a small amount of urine behind with each trip to the toilet. That leftover urine is the seedbed for tomorrow's bacterial growth. Many people notice they need to rush to the toilet and yet pass only a small amount. Many notice dribbling or a feeling of incomplete emptying. Many also notice stool accidents or streaks in underwear. When urinary and fecal control both slip, the two problems are often linked by stool loading. Addressing stool burden is not an optional extra. It is the center of prevention. Some medicines and conditions quietly slow the gut and set up the bladder for trouble. Review your daily medicines and your chronic conditions with this simple lens. Medicines with anticholinergic effects, opioid pain medicines, iron tablets, some calcium channel blockers, and medicines with strong antihistamine effects all slow bowel movement. Dehydration, limited mobility, diabetes with nerve changes, and low thyroid function all add friction. None of this is a moral failing. These are predictable effects. When recurrent bladder infections appear, a structured medicine review with your clinician to reduce bowel slowing is often more powerful than an extra antibiotic course. If this pattern sounds familiar, plan one change you will discuss with your clinician this week. Pelvic organ prolapse changes the plumbing, and microbes exploit the change. Over the years, childbirth, chronic cough, heavy lifting, or simply the slow shift in connective tissue can let the bladder drop forward into the vagina. This is called a cystocele. A cystocele can create a pocket in the bladder that does not empty well. That pocket behaves like a small pond with still water. Over time, still water hosts bacterial life. People may notice a feeling of something bulging, a heaviness in the pelvis at day's end, or urine that dribbles after standing up. A simple pelvic exam can often identify this. Support can be mechanical, like a well-fitted pessary that holds the bladder in a better position, or muscular, like directed pelvic floor therapy that trains the right lift and timing. The aim is not only to have fewer leaks, the aim is a bladder that empties cleanly so bacteria have fewer places to hide. Diverticular disease can form a tunnel between the bowel and the bladder that keeps infection going. In some older adults with a long history of diverticular disease, a tiny passage can open between the colon and the bladder. This is called a fistula. A fistula allows gas and bacteria to travel directly into the bladder. People may notice bubbles in the urine, a strange odor, or infections that return soon after treatment with mixed bowel-type bacteria in the culture. When this pattern appears, imaging or a look inside the bladder often confirms the diagnosis. Antibiotics alone are not enough in this scenario because the source is a tunnel, not only a migration over the skin. A surgical plan may be part of the solution, and when the tunnel is closed, infections usually settle. Catheters and biofilms make the gut-to-bladder link even stickier. When a catheter remains in place for weeks or months, bacteria form a film on the tubing and inside the bladder. This is expected and is called colonization. Colonization is not the same as infection. Treat when there is new burning, urgency, fever, pelvic or flank pain, or a clear overall decline tied to urinary symptoms. Do not treat a positive culture alone. Each unnecessary antibiotic damages the helpful microbes in the gut, opens the door for tougher organisms, and raises the risk of a dangerous gut infection called Clostridioides difficile diarrhea. The safest practice is to test only when new urinary symptoms are present and to treat only when a clear infection is identified. This protects the gut, and by protecting the gut, it protects the bladder. Confusion, fatigue, and a positive culture are not proof of infection by themselves. Asymptomatic bacteriuria is common in older adults, so a culture that grows bacteria is not a free pass to antibiotics. Treating colonization does not lower risk and adds harm. If there is no burning, no urgency, no new frequency, no pelvic discomfort, no flank pain, and no fever, then the safest plan is often to hold antibiotics, look for other causes of the symptoms, and check the gut. When we reserve antibiotics for true infections, the gut community recovers, the bladder sees fewer aggressive microbes, and the cycle begins to break. Now that you see the roots into the bladder, you can build a daily plan that closes those roots. Prevention starts in the morning, not at the pharmacy. When you wake up, the body triggers a wave in the colon that is strongest within the first hour of breakfast. Use that wave, sit on the toilet after breakfast, feet supported on a small stool or a thick book so the knees sit slightly above the hips. Lean forward, rest your forearms on your thighs, breathe slowly, and relax the belly. Allow a full 5 to 10 minutes without rushing. This position straightens the anorectal angle and helps stool pass with less straining. Even if nothing happens the first few days, the rhythm will return with practice. A gentle routine is better than a forceful push because straining enlarges the rectum over time. Hydration is not about chasing a number. It is about making stool soft enough to move. The colon saves water for the body and will pull water out of stool when you are underhydrated, when you have long gaps without fluid, or when you take in many caffeinated or alcoholic drinks. Aim for regular sips throughout the day. Most older adults do well with 6 to 8 cups of fluid daily unless a clinician has advised a restriction for heart or kidney conditions. Water is best. Broth, herbal tea, and diluted fruit infusions are fine. If you live with heart failure or advanced kidney disease, follow your personalized fluid plan and ask your clinician how to adjust stool softeners within your safe range. The goal is a soft, formed stool that passes once daily or every other day without straining. Fiber is the framework that holds water in stool. It must be built gradually. Think of fiber as a sponge. Soluble fiber holds water, making the stool soft and gel-like. Insoluble fiber adds stretch and bulk that helps the colon push. Oats, barley, chia, ground flaxseed, psyllium husk, beans, lentils, vegetables, and fruit skins bring different blends. Start low and go slow. Add 1 to 2 teaspoons of psyllium or ground flaxseed to your breakfast for 1 week. Then increase by 1 teaspoon each week until you find an amount that keeps your stool soft without causing gas or cramping. Many adults consume between 2 and 6 teaspoons daily. Pair every increase in fiber with an extra cup of fluid. If you live with chronic kidney disease, be mindful of high potassium foods like dried apricots, prunes, and certain legumes. Work with your clinician or dietitian to adjust choices so you stay within safe potassium limits while still getting enough fiber. If you take warfarin or other anticoagulants, keep your green vegetable intake steady day to day so your medicine dosing remains stable. Here is a breakfast example. Oatmeal cooked with water, topped with chia and blueberries, plus 1 cup of water on the side. And here is a dinner example. barley and lentil soup with a mixed vegetable side, then a slow 10-minute walk. Movement is medicine for both the colon and the bladder. A short daily walk after meals wakes up the nerves of the gut and helps the bladder relax and empty. 10 to 15 minutes after breakfast and dinner can be enough to build momentum. Gentle abdominal massage, working clockwise from the lower right belly up and across, can stimulate a sluggish colon. Chair rises, light stair climbing, and simple balance drills help the pelvic floor learn to tense and relax on command. The aim is coordination, not force. A pelvic floor that can relax during urination and stool passage protects against incomplete emptying. If you leak when you cough or you struggle to start the urine stream, a few sessions with a pelvic floor therapist can be transformative. Toilet access and privacy are part of medical treatment, not extras. Many older adults limit fluids to avoid public toilets or to avoid asking for help. This backfires by drying the stool and tightening the bowel. Make bathrooms easy to reach at home with clear paths, night lighting, and clothing that is simple to manage. Caregivers can help by offering regular toilet opportunities at predictable times, like after meals and before walks. For those in assisted living or nursing homes, scheduled toileting and stool logs are frontline therapies. Dignity is medical care. Privacy is medical care. A calm seat and enough time to finish medical care. Mistakes and fixes that change the gut to bladder story fast. A few predictable mistakes keep the cycle going. Treating every positive culture is the first step. The fix is to treat only when urinary symptoms and a test match. Ignoring constipation and stool burden is the second. The fix is to assess, soften, and empty before another antibiotic. Leaving constipating medicines in place during a run of infections is the third. The fix is a deliberate medicine review to swap or lower agents that slow the gut. Missing prolapse is the fourth. The fix is a simple pelvic check and support with a pessary or therapy when needed. Saving antibiotics as a first step instead of a last step is the fifth step. The fix is to build a bowel routine, optimize bladder emptying, and use antibiotics when they are truly needed. If one of these fixes helped you end a streak of infections, share your story in the comments so someone else can copy your move. A clear, stepwise home protocol keeps you safe while you and your clinician work together. Build a daily and weekly rhythm. Day by day, drink a cup of water upon waking, eat a fiber-rich breakfast, sit on the toilet after breakfast with feet supported, walk for 10 minutes and take your stool softener or laxative exactly as planned rather than as needed only. Midday, sip fluids and include a vegetable and a bean or lentil in lunch twice each week to start. Evening, sit again after dinner for a relaxed attempt and take any evening stool softener or laxative as prescribed. Week by week, increase fiber by a teaspoon, add one more walk, and check your stool log. A one-page stool diary with boxes for texture, effort, and frequency helps you and your clinician see patterns and adjust safely. Stool softeners and laxatives are tools. Using them on a schedule is safer than chasing symptoms. The colon learns routines, so tools work better when used consistently. Osmotic agents like polyethylene glycol draw water into stool and are often gentle enough for daily use. Bulk-forming fibers like psyllium need water and time. Stimulant laxatives can be used short-term to clear stubborn stool, but may cause cramping if used daily. Suppositories can help empty the rectum when the urge is present, but the outlet is tight. Enemas are reserved for specific situations and should be guided by a clinician. If you have heart or kidney conditions, ask for a personalized plan that respects your fluid and electrolyte limits. If you have rectal bleeding, unintentional weight loss, or pencil-thin stool, seek medical evaluation before adjusting laxatives. Safety comes first. Timed voiding and double voiding reduce residual urine when nerves or muscles are slow. Some older adults with diabetes or nerve changes feel less urge to urinate and may leave more urine behind. A simple schedule to urinate every 2 to 3 hours while awake can prevent overfilling. Double voiding means relaxing for a minute after you finish, then trying again without pushing. This second pass often empties a hidden pocket. Pausing and relaxing the pelvic floor during urination, rather than pushing, helps the bladder do its job. If you hear trickling long after you stand up, sit again and allow the last few spoonfuls to exit. Men need one extra checkpoint for the same gut-to-bladder pathway. Men can have repeated infections when the prostate is enlarged and the bladder does not empty. Slow flow, starting and stopping, and dribbling point to residual urine. Timed and double voiding help, and a clinician can assess whether medicine or other steps are needed to improve emptying. The principle is the same. Less residual urine means fewer places for bacteria to grow. Sexual activity, hygiene, and skin care are about mechanics, not blame. Sexual activity can move bowel microbes closer to the urethra. Urinating soon after intercourse and drinking a glass of water can help flush the entrance. Avoid spermicides if you have repeated infections, as they can disrupt helpful microbes. Wipes with alcohol or strong fragrances can irritate the skin and make micro breaks where bacteria settle. Replace tight synthetic underwear with breathable cotton. Small mechanical changes reduce friction and lower risk. Nutrition tweaks support both the gut microbes and the bladder lining. A balanced gut community resists overgrowth by aggressive strains, so favors simple, steady patterns. Include vegetables daily, beans or lentils several times per week, and whole grains like oats and barley. Fermented foods like yogurt with live cultures, kefir, and sauerkraut can support microbial diversity for many people. If dairy bothers you or you live with lactose intolerance, choose lactose-free options or plant-based ferments. If your odor is strong, add 1 extra cup of water and 1 serving of fresh fruit each day for 1 week and reassess. Avoid frequent sugar-sweetened drinks, which can feed less helpful microbes and worsen stool pattern. If you notice that a specific food pattern improves your bladder comfort, note it and keep it in your routine. When vaginal tissues are thin and dry, local estrogen may restore a key line of defense. Clinicians often consider low-dose vaginal estrogen in postmenopausal women with repeated urinary infections and signs of atrophic vaginitis. This is applied locally, not swallowed, and aims to rebuild the health of the tissue and the balance of local microbes. Decisions depend on personal history, including past estrogen-sensitive cancers. Your clinician will guide you on whether this is safe in your case. When appropriate, this single change can lower infection frequency by making the neighborhood less friendly to bowel microbes that wander. Red flags tell you when gut first is not enough and urgent care is needed. Do not try to ride out severe signs. Seek prompt care if you have a fever, chills, back or flank pain, vomiting, confusion with severe illness, or blood in the urine. These can signal a kidney infection or another condition that needs immediate attention. If you have persistent bubbles in urine, foul urine with gas, or infections that return within days of finishing antibiotics, ask about a possible fistula. If you are a man with repeated urinary infections, a prostate evaluation may be needed because bladder emptying can be blocked for reasons other than stool burden. Safety is strength. A simple self-check keeps you oriented when symptoms flare. Each time urinary discomfort begins, pause and run this 5-point check. 1. Are there true urinary symptoms like burning, urgency, or pelvic discomfort, or is this primarily fatigue or confusion? 2. Have you had a new bowel slowdown, harder stools, or skipped days? 3. Have you changed a medicine that could slow the gut? 4. Did you drink far less in the past 2 to 3 days? 5. Did you change sexual activity, soaps, or clothing that increased friction? If points 2 through 5 show a shift, begin by restoring the bowel and the daily rhythm while you connect with your clinician to decide if testing and treatment are needed. Testing is a tool, not a trap. When a urine test is ordered, make sure the sample is collected cleanly and at the right time. A midstream clean catch after gently washing the area reduces false positives. If you use a catheter, ask how best to collect a fresh sample from the tubing port rather than the bag. Remind the team that you prefer to avoid antibiotics unless symptoms and tests both support an infection. This stance protects your gut, your bladder, and your future self. Care plans succeed when they are shared and simple. Involve a partner, a friend, or a caregiver in small ways that matter. Share one weekly goal, like adding 1 fiber serving at breakfast or taking a 10-minute walk after dinner. Set a friendly check-in each Sunday afternoon to celebrate what worked and adjust what did not. If you like technology, a basic step counter and a reminder app can help you remember toilet after meals and fluid breaks. If you prefer paper, a small notebook on the kitchen counter works just as well. The tool matters less than the routine. Your clinician's role is to clear the path while you steer the daily choices. Ask for support in a few targeted areas. Request a medicine review to reduce anticholinergic burden and other constipating agents when possible. Ask for a pelvic exam if you have heaviness, bulging, or dribbling. Ask whether a pessary might help you empty better. If you have diabetes, ask for support to improve blood sugar steadiness, which improves nerve function over time. If you have low thyroid function, ensure your dosing is optimized, since sluggish thyroid slows the gut. If a catheter is in place, review the reasons regularly and remove it as soon as it is no longer needed. A one-page prevention plan turns knowledge into fewer infections. Prevention can fit on a single sheet. Morning, drink 1 cup of water, eat a fiber-rich breakfast, and sit on the toilet with feet supported for 5 to 10 minutes without straining. Midday, sip water with meals, include produce and a fiber choice, and take a 10-minute walk. Evening, repeat the sit after dinner, review your stool log, and prepare fiber or stool softeners for the next day. Weekly, increase fiber by 1 teaspoon if stools are still hard, add 1 extra walk, and review medicines with your clinician if constipation persists. Monthly, check that your bladder empties without dribbling after you stand. If you hear late trickling, sit again to finish. This is how small daily moves become long-term bladder protection. Real examples make the principles clear. Maria is 74 with a year of recurring bladder infections. She takes a strong nighttime antihistamine for sleep and an opioid pain pill for an old shoulder injury. She drinks little water so she does not need to use the bathroom at night. She moves her bowels every 3 to 4 days with straining. Her plan is to taper off the antihistamine with her clinician, swap the opioid for a non-opioid pain strategy, drink a cup of water on waking and another with lunch, add a teaspoon of psyllium each morning and sit after breakfast and dinner. 2 weeks later, her stools are soft and daily. 2 months later, she has had no bladder symptoms. The culture problem was a gut problem. Your takeaways are simple, but they are powerful. The gut-to-bladder link is not a theory. It is the daily reality of a small space where the bowel, vagina, and urethra lie shoulder to shoulder. Soft, regular stool and complete bladder emptying close the door that microbes use most. Medicines and conditions that slow the bowel open that door. Pelvic anatomy can hold it open unless we support it. Antibiotics help when there is a true infection and harm when there is not. Your most important work is gentle and repeatable, not heroic and hard. Your next step is to choose one lever and put it into practice today. Action cements learning, so pick one change that fits your life. Add 1 teaspoon of psyllium to breakfast with a cup of water, or schedule a toilet sit after breakfast with a small stool under your feet, or take a 10-minute walk after dinner. Or call your clinician to review a medicine that seems to slow your gut. Tell me in the comments which single step you will try for 7 days so others can learn from your plan and come back next week to report your results. You deserve a bladder that feels calm and predictable, and a gut that moves with ease. You now understand where many infections start and how to close the door they use, so you can steer your daily choices with confidence. You are not waiting for the next prescription. You are building a small set of habits that change the terrain. If this helped you see the problem in a new light, subscribe so you do not miss the next lesson that builds on this one.